actually understand.
The concept of flexion and extension, or nutation, counter-nutation, should be relatively simple. Right? During inhalation, take a big breath in. If we're lying supine or resting prone, what would we normally expect to experience during inhalation? Nutation or counter-nutation? Counter-nutation. We normally experience the base of the sacrum, or the top of the sacrum, moving posteriorly. Sometimes when it's done from a standing position, you'll have the opposite of that. But usually when we treat, we're evaluating and treating from a supine or prone position. So that typically the experience then is during inhalation or voluntary respiration, we get a posterior movement of the sacral base or a counter-nutation type of movement or mechanical extension. Okay? During exhalation, it's just the opposite. During exhalation, the base of the sacrum in a supine or prone position tends to move anteriorly or nod forward. Therefore, we call it nutation. The theoretical axis about which it's rotating is a transverse axis going from top to bottom around the second sacral segment, somewhere on between S2, S3, somewhere in that area. It'll vary a little bit based upon how the person's put together, how their particular pelvis is arranged. Okay, it's not the same for every single person, but it's generally a forward-backward type of movement around the second to third segment, somewhere in that vicinity, is what most anatomy people think or believe. Okay? All right. Torsions. We talked briefly. Physiologic torsions. They call them physiologic because they're physiologic in the sense that they normally, from theory, go through this pattern during a normal gait cycle. So when someone is walking, we have basically kind of like a left on left, then a right on right, and a left on right, right on right. It keeps transferring back and forth. We describe them in a way to remember which ones are physiologic torsions. They have the same letter. Right on right, R's, or left on left, the L's. Those are the anterior torsions, or physiologic torsions, or some books refer to them as forward torsions. Forward torsions. Okay? If we use the idea that this is the sacrum, okay, and we're going to run through, say, a diagnosis algorithm, we usually will start with a seated flexion test. Seated flexion test. If one thumb rides up high compared to the other thumb, and assuming that it's a true positive, that's considered a positive seated flexion test. That simply gives us the side by which we're going to start to name things. So say if the person bent forward and the right thumb rode up or elevated compared to the left, we would say that the right side was positive. Okay? We then would need to check the overall movement of the sacrum. Usually you have the person lie down, or you could have them supine. You do a sacral rocking kind of movement. They could do it with inhalation, exhalation, and you'll rock with it, sacral rock. If the sacral rock movement is what you wouldn't normally expect, it feels a little off, it has camber to it, it feels ratchety, it doesn't feel normal, that then is considered a what? A positive sacral rock test. Yes?
When you do your sacral rock, are you just doing it with the respiration, or are you actually physically pushing it?
Yes. I'm doing both. I'm augmenting what I normally would expect to find with respiration. Okay? That would be a positive sacral rock test. The next typical test that can be done, and it makes sense, is to check the corners. Top corners, bottom corners, and I have it like this, but these are really kind of angled this way. Right? So you're looking at these corners, and these, what they call inferior lateral angles. Alright? The top two poles and the top two bottom poles, these are the superior poles, inferior poles. These are the ILAs. Okay? Superior, inferior, ILAs. Superior poles, inferior poles tend to be anterior, posterior type structures, ventral, dorsal, that type of positioning. The inferior lateral angles tend to be cephalad, caudate, or superior, inferior type of positioning. Okay? And then we shouldn't forget that there's typically a relationship between what? L5. That's the spinous process there. Okay? L5 with this as well. All right, so let's go through it. Positive C deflection test on the right. Okay, positive sacral rock test. It doesn't feel correct, doesn't feel normal. We check the corners. We check these two against each other, these two against each other. And what we see is that, say, this corner here in this particular example, this corner appears to be deep, or this sulcus, as you might call it, appears to be deep, whereas this one feels shallow. So this one feels deep, this one feels shallow. You check these two compared to each other, these inferior poles to each other, and you find that this one seems to be relatively posterior, while this one is relatively anterior. Okay? Relatively posterior, relatively anterior. Now, we're going to stay with the idea that we're talking about physiologic torsions, or anterior torsions, or forward torsions. Okay? In a torsion situation, if it's following the normal torsion theory, the axis should be on the side opposite that of the positive C deflection test. Okay? Positive C deflection test. This is a C deflection test. Okay, C deflection test. So if the axis follows suit, it should be where? An oblique axis. Okay, an oblique axis. So this is the left side. So it's a left axis. The rotation then is going to be described based upon this relationship. If this is deep and this is shallow, if we were to imagine for a second that this was a vertical axis instead of an oblique axis, and this was deep and this was shallow, which way is it rotated? Left. Rotated left. Okay? It's rotated to the left. It's rotated to the left. Okay? It's rotated to the left. My three-dimensional drawings. Rotated to the left. So we would describe this as a left rotation, left rotated on a left axis. Left rotation on a left axis. Positive C deflection test on the right. Positive sacral rock test. Four corners show this right corner is deep compared to the left, which is relatively shallow compared to that. This side, the left-hand inferior pole, is relatively posterior compared to the right pole, which is relatively anterior. And we'd find that the inferior lateral angles may or may not be level. They may be slightly unlevel. It's not the biggest thing. All right? We'll talk about the ILAs more specifically when we talk about shears. Okay, when we talk about shears. But for torsions, these are less of a significance. There might be a little bit of a side bending to this, but that's not the predominant finding. All right?